right, good evening, everyone. Thank you so much for joining us today. Definitely glad to see the wonderful turnout. And because you were all on time, I think we deserve to start on time as well. All right, so let me get my slideshow in place. All right, I hope everybody is seeing the screen clearly. If I can get confirmation, that'd be great. Is everyone hearing me?
We're seeing the screen.
Awesome, thank you so much. All right, so welcome everyone to another edition of Life Talks. My name is Joette Mackenzie, one of the research assistants working on the Living in Full Health Project, or the LIFE project. And this month, sorry about that, this month we'll be focusing on heart disease and its risk factors. We encourage you all to join us next week, or next month rather, as well, where we'll be talking about checking for heart diseases and of course what to do to know if we have it. But for this month, we want to focus on heart disease and its risk factors. So for those of us joining us for the first time, the Life Talks are a series of discussions where we focus on different topics or health conditions each month. It's one of the ways we keep in touch with our participants, where we give them the opportunity to ask questions. We also encourage others living in our study communities to sign up for the project once they are eligible to do so. You can find all our talks on our YouTube channel titled UWICAIR. So just type in UWICAIHR. And remember to follow us on Instagram as well at the Life Project JA. And to keep up with our project activities, you can visit our website, lifeprojectja.com. So to discuss with us about heart disease and its risk factors is one of our own care unit directors who is based in Barbados. Professor Simon Anderson is actually director of the Georgia Lane Chronic Disease Research Center and is a professor of population health. Prof. Anderson actually studied biochemistry here in Jamaica, from where he won the Cambridge Commonwealth Scholarship to study epidemiology at the University of Cambridge in England. And then he subsequently studied human biology and genetics at the University of Oxford. And then he trained in medicine at Cardiff University in Wales. He held a prestigious NIHR clinical fellowship and an NIHR clinical lectureship during his postgraduate training in academic cardiology at the University of Manchester, honing his skills at the George Institute of Global Health, Oxford, and Farr Institute of Health Informatics Research, University College London. So his subsequent, or his subspecialty rather, is clinical cardiology, where his training was in heart failure and transplantation, undertaken, of course, at the Manchester University Foundation NHS Trust UK. So Prof. Anderson is definitely an expert in heart, and of course, you will be able to ask him your questions towards the end of our discussion this evening. So before we get into our talk tonight, we want to send big thank yous to everyone who made this possible, to our participants, first off, for being a part of our project, or community liaisons who helped to spread the word in the communities, or data collectors, drivers, or phlebotomists, or community health aides, or med techs, research nurses, research assistants, investigators, everyone who played a major part in this project thus far. Thank you so much. And before we get into our discussion segment, we are going to start off with an overview of the project. Just a reminder of the levels of heart disease in Jamaica and why we continue to push to do as much as we can to understand the different health conditions. So far, we have been focusing on non-communicable diseases for our live talks. So those are diseases that you can't catch from other people, right? We've done diabetes, hypertension, prostate cancers, and like I said, now we're going to be talking about heart disease. And in Jamaica, we have data to show that 1 in every 3 deaths is tied to cardiovascular disease or heart disease. In terms of the other NCDs, by age 50, 1 in every 2 women is obese, as opposed to 1 in every 5 men. When we look at hypertension, 1 in every 2 women is living with hypertension, whereas 2 in every 5 men. And then when we look at diabetes, 1 in every 5 women is actually living with diabetes as opposed to 1 in every 10 men. All right, so understanding the different factors that contribute to these diseases becomes even more important as the rates increase. And so the LIFE project is actually geared at identifying the risk factors for these non-communicable diseases, the diabetes, the heart diseases like strokes and heart attacks, cancers. All of these, of course, are leading causes of death in Jamaica, Caribbean, and of course, the wider world. And so for the LIFE project, we're actually asking 8,000 Jamaicans about their lifestyles. So their eating habits, drinking of alcohol, that is, physical activity habits, medication use, family history of disease. And we're doing body measurements such as the height and the weight and, measuring the waist circumference and checking for the fasting blood sugar, glucose. And most importantly, we're following up the same persons over time, which is why it's called a cohort study or a follow-up study. So some persons might ask, do you have to have these diseases to be a part of the project? And the answer is no. We want to actually be able to compare the lifestyle and the habits and the measurements of those who have the diseases, those who don't, those who go on to have the diseases, and of course, those who don't. To be a part of the project, you either have had to been a part of the Jamaica Health and Lifestyle Survey 3 back in 2016, 2017. If not, then you would have to be between 30 to 70 years old, be a permanent resident in one of our study communities. And of course, a list of communities is actually on our website. So if you want to participate, you can, reach out and take the small quiz to see whether or not you're eligible. And of course, you're not planning to migrate in the next 3 years. Both males and females are welcome, but females can't be pregnant at the time of enrollment. Not to say that you can't get pregnant afterwards, but at the time of enrollment, because the lifestyle questionnaire and the measurements are important in the non-pregnant state. So we seek your participation for those who are contemplating or are on the fence. Participation will help you to understand your health, whether it's through the questions we ask in the questionnaire or the measurements and the free lab test, the feedback that you get. But we will also be able to identify the important risk factors for these non-communicable diseases, find new ways of detection, prevention, and of course, treatment. So just to give a little visual of our work in the field, to the far left, you see our phlebotomist actually pulling the blood. And of course, in the middle, you have our participant cutting nails. And the third picture showing the phlebotomist with, urine recently collected. And the last picture to the far right is actually one of our venues. So again, huge shout outs to our churches for allowing us to use a space, a central location where our participants can come gather and get their different samples collected or body measurements. So for the far left, we see a participant having his blood pressure measured, and in the middle, we have our nurse actually doing the height, and the third picture showing the waist circumference being measured, and of course, the last one, the neck circumference. So it's neck, waist, and hip circumferences. All right, so that is a brief overview of the project. And at this time, we are going to get into our discussion segment. So like we said earlier, joining us today is Professor Simon Anderson, and I see different greetings in the chat. Of course, we have Dr. Edwin Toller-Reid with us, joining us this evening as well. So our discussion, no doubt, will be a great one. So without further ado, let us get into our question segment. So Prof. Anderson, if you want to give a word of introduction, meaning hello, I'm sorry, you can please go ahead and do so now.
All right, so I'm going to say good morning, because it's morning where I am in the Philippines. I'm in an island called Palawan.
Awesome.
And here I've come to work with our colleagues at the Western Philippines University. It's about health and food production and food security, but everything ties in together, as you'll see. I won't stay on live with the video running because the stream and bandwidth might be difficult, but I just wanted to say thank you for inviting me and for your very kind introduction. And I also wanted to say hello to everybody who's joined on the stream, including my very good friend, Dr. Edwin Toller-Reid, who actually convinced me that medicine was a good path to take.
Yes.
That was many, many years ago, before much of the cohort here was born.
Might not be so. We do have some, older participants as well. But thank you so much, Prof. And again, we do appreciate the challenges with Zoom and streaming. So thank you for the heads up about the video as well. All right, so the first question, the big question, number one question, what is heart disease? Tell us a little bit about heart disease.
Right, so the one thing that people listening should understand is that when we refer to heart disease, it's a reference to multiple or several types of heart conditions. The most common one that affects people is the disease of the vessels of the heart, which is called coronary heart disease, and that is because of reduction in blood flow in the vessels, and therefore the muscles that is working to pump blood around your body, they don't stop from life to death. So they are put on a little bit of pressure, a little bit of strain. We call that ischemia, when oxygen levels are lower than expected, and that can cause pain and lead to several outcomes, including a heart attack or other problems like heart failure, which is really a pump failure, because the heart, as everyone should understand, is a pump. There are also conduction problems within the heart. We use the technical term, when I say conduction problems, if you consider your house with its electrical wiring through it, well, the heart is similar to a house with its electrical wiring through it. And if there are problems with your wiring system, in other words, there's a short or something, then you get arrhythmia or irregular beating of the heart or irregular functioning of the heart in terms of its beating capacity. Because most of the time when you put your hand on your heart, over your chest where your heart is, you can actually feel the rhythm of your heart, and it seems to be quite synchronous and steady. But sometimes it can become quite fast, and in other situations, it can become quite slow. Or it might just become a very ad hoc, irregular beating pattern. And all of those have consequences in the long term towards your health. And then there are problems with the heart because the muscles get too big. So you have what we call a dilated or a hypertrophic heart. Those are two separate things. There may be invasion of the heart of other things like infections and so on. Those could cause heart problems because the valves of the heart don't work. And if the valves of the heart don't work, then the pumping is ineffective. So that is sort of heart disease in a nutshell. And I think if I were to talk another half an hour, I could even give you more subtypes of heart disease problems. But because time is of an essence, I'll stop at that point.
Yeah, I mean, and you started, which I definitely appreciate, because my next question was going to be, what are some of the different types? And you mentioned ischemic heart disease, and if you can, just elaborate a little bit more as well, and, drop in a few symptoms and, physical indicators, that would be great as well.
Okay. All right. So, and I'm going to say that, Dr. Tollery, please jump in if your student is going in the wrong direction. I'm sure I'll be fine. So in terms of the various types, as we mentioned, ischemic, and I tried to explain that is when the oxygen supply to the heart muscles are limited because the blood flow through vessels are damaged, and the typical sign and symptoms from that include chest pain. And most times when people first have chest pain, that's when they first understand that they're having something what we call a heart attack. So the pain might be in the form of indigestion or heartburn, or some people don't even have any pain at all. They just get a bit of nausea and a bit of vomiting. Some become extremely fatigued and breathless and dizzy. Those are some of the symptoms that happen when the heart is not operating at its normal capacity. If it's a problem with the conduction system in the heart, where we get the different fast or slow or irregular beats, then people might get something we usually say palpitations, but in the old days we might say flutterings and so on of the heart. And in terms of heart failure, which is the pump failure, the key problem, the key symptoms are shortness of breath, tiredness. But people can see what we call signs in the clinical terms, which is ankles get swollen. There is enlarged neck veins in the neck. There are other problems in relation to mobility, not able to walk very far, can't climb the stairs. Those are all sorts of things that are associated with heart disease.
Okay, great. And you mentioned palpitations and chest pains. How does it differ from angina?
Okay. So in general term, and angina is typically associated with the lack of oxygen, the ischemia side of the heart disease problem. It's usually painful. So angina can be it's a spectrum of pain. It can be pain at rest, which is usually indicative of a really dire situation, or it can be pain on exercise. So you normally go for a walk and you could do a kilometer and find that after 500 meters you get a little bit of tightness in the chest, or even something simple like climbing up a flight of stairs that associated with a little bit of usually if you visualize it, the books and will always show someone with a belt tightening around the chest. So you'll see that almost as if there's the chest can't expand as much, but that's the sensation that people have, and that's how it's described visually. So that's really what angina is. Angina can come from the blood flow problems, or if somebody has a very fast or typically fast heart rate, then of course the heart is working harder
over time,
which means
right.
that its demand for oxygen is more, and therefore you will get a little bit of chest pain related to that. So all of these things are part and parcel of angina. It doesn't have to be that you have the artery problems that causes you to get angina. Angina can come from fast rate, fast heart rate as well.
Okay. And I mean, some persons might have to, prop up their feet or sleep on 2 pillows in order to help with breathing at night as well during sleep. So thank you so much for that.
Yeah.
All right. So
yeah, just to add to that before you go. So this is now related to heart failure, where what tends to happen is with the breathlessness, people find that they can't lie flat. They need to have multiple pillows. It gets to the stage where they are required to sit up at night in order to be able to feel like they're breathing properly. Some of these symptoms can occur in other disease. They are not specific to heart disease. So people who have respiratory or pulmonary diseases or problems will have some of these symptoms as well. And those individuals can have perfectly normal hearts. So we want people to understand that symptoms and signs can be distributed across any condition. It doesn't necessarily mean that the term that we used to use is pathognomic. It doesn't, not everything is specific to the condition. Sometimes you have multiple conditions sharing some symptoms and signs, yes.
Right. Okay, thanks for that. All right, so can I have a heart attack and not know? Is that possible?
Sadly, it is possible. And some people only recognize that when they go off, they might go off to do a test, have an ECG, or they go off to have a scan of their heart, and they suddenly start having problems of breathlessness, and then it is discovered that they would have had a heart attack in the past. So you have the big vessels that supply the heart with blood, and you have the small vessels as well. So they're called microvessels and the large arteries of the heart. And so depending on where the issue is, you have to consider it almost like irrigating the land. If you set up an irrigation system for your farm, and there is a blockage or a narrowing of the water flow to where you want it to irrigate the land, then what you'll find is that some areas get irrigated nicely and other areas don't get irrigated at all. It's the same thing that's happening in the heart muscle. So you can get this patchy sort of change in the oxygen supply, and that can be a silent thing. And so there are critical signs that you see on an electrocardiogram or an EKG in American parlance. So you can look at the ECG and tell, because it's looking at the electrical activity of the heart. You can tell if the heart has had a heart attack before, because there's some signs on the ECG that give you that. Or you might find it on a scan of the heart, what we call an echocardiogram, where you look at, actually, it's almost like the same thing that you would do if you're looking at a little baby in the womb. You get an ultrasound scan. You can do an ultrasound scan of the heart, and you can see segments of the heart not pumping in synchrony, and you can make the inference there that was related to a heart attack. So yes, it is possible to have a heart attack and not know, and people will go through their lives and live full lives and will never know that they may have had a heart attack before. So not all the time you have symptoms. Okay.
And then of course you can have multiple heart attacks, and you can have heart attacks where you can be hospitalized for days. Have you ever, had an experience with a patient being hospitalized for a heart attack, and of course, how many days, and what's the most severe that you come across in your experience?
All right. So in terms of severity, the most severe patients are those whose heart literally have packed in and they need a transplant. That's the most severe. And those individuals tend to be in hospital for quite a while because they need to get a donor to get them a heart. But in terms of a heart attack and ischemic, what we call it ischemic heart disease, it's also a spectrum as well. So some people will come in and we base it on the signs that we see on the EKG or the ECG. So if someone has chest pain and they present to me on the ward and I do this EKG, there are blood tests that I can do that will give me a very specific answer. Because what happens is that if there's pain in the heart and there's damage to the heart, then that some of the structural components of the heart itself, or the muscle, breaks down and goes into the bloodstream. So we can, what are called troponins. We can measure those, or we can measure cardiac markers. We can look at the ECG and you might say, okay, well, this is not a very major situation, so we need to change this is now where we're doing secondary prevention. Most people, you want to stay in the primary prevention phase, but you never had it before. But if you have had the symptoms and it's found to be a heart attack, then you might get various tablets to reduce your cholesterol, to reduce the pain that you get from the heart, and to improve the pumping ability of the heart. So those things can happen, but in the more severe cases, we may have to do what we call an angiogram, which is really the ability to visualize the heart vessels and to see where the narrowings or the blockages are. And skilled persons like Dr. Tullereed can go in and try to open up the pathway to get blood flowing again. Those would probably take 2 or 3 days to resolve. But then what you might go and find it, and the situation in the vessels of the heart is too significant, that put enough stents and balloons and so on to open the pathway is not sufficient. And in those situations, some people might need to have what we call a coronary artery bypass grafting, or just surgery, on open heart surgery, to create a new conduit for blood to flow from one area to the next, to arrange to allow the oxygenation of the heart to improve. So that would take a little bit longer. That person might be in hospital for a week or 2 as they recover. And then you'll have the situation where, and it's usually not related to coronary artery disease. It's probably related to some heart failure related matter. Sometimes it's genetic. In other words, you've got that condition through your family, or based on changes in the genes that make the or the proteins in your heart. And if you have that situation, then in those cases, you might want to have some places in the world can offer people a heart transplant, and offer the heart transplant. Then you have to find the right heart, and you have to keep the person what we call optimally managed, so that they're ready for surgery, etc. And that might take a little bit longer. So that's sort of the range of what can happen.
Wow. Yeah. And I love how you moved on to the genetic side of things, because we have both modifiable and non-modifiable risk factors for heart disease, and knowing a family history can really be important. Can you just elaborate on that a little bit? The role that genetics and family history plays. Sorry, you're still muted.
Yeah, thanks. So this is a critical point to make for a community, and I'm talking about the community in the Caribbean, not just Jamaica, but across the board, where we need to have a better understanding of some of the you say, non-modifiers, the factors, the risk factors that happen, because you can't do anything about it. For example, a good example of a non-modifiable risk factor is one's gender. If you're male or female, you can't change that to any extent in terms of your risk of heart disease. But there's also the genetic side of things. So proteins in how the body is designed to be to make what it requires for the various organs and muscles, etc. So either proteins to make them function, or proteins to structural proteins. So the heart muscle is a good example. And it from time to time, an individual might be found to have an anomaly, or these may be related to sort of changes that occur over one's lifetime, or it might be just something that happens out of the blue. Not always you can give an explanation for that. And in those situations, you get conditions to the heart, usually the heart muscle. The heart might be too big or too or too thick in terms of how it operates, or there may be other problems with valves and so on, which require some intervention. So like sometimes people, the main valve of the heart is a 3-leaflet valve, and sometimes people are born with 2 leaflets, and eventually as they get older, it becomes a problem with pumping. So then you have to have step surgical or other steps to correct those things. I don't know if that's answered the point.
Yeah, and I mean, you tied in the aging as well, which is one of the other non-modifiable risk factors as well for heart disease. So definitely, thanks for that. All right. So before we jump into the modifiable risk factors, I just wanted to touch on stroke a little bit. And of course, I go right back similarly to the heart attack and not knowing, can I have stroke, and not knowing, different persons might have stroke in different forms. So if you could elaborate a little bit about stroke.
Okay, so just to make clear to our listeners that when we talk about stroke, we're talking about events in the brain, affecting the brain as an organ. And the brain as an organ has its blood supply just as the heart as an organ has its blood supply. And what tends to happen in the body as we age, and it might be also occurring because of some other accidents related to smoking or consuming of alcohol, or other having problems with blood clotting, etc. Those can contribute to blood vessel damage and lack of oxygen supply to areas of the brain. And unfortunately, what happens is that if the blood supply to a territory of the brain is blocked off, then this is what happens, is what we call a stroke. And it tends to be called a stroke if the signs and symptoms that you see. So for example, people talk about weakness on one side or something related to their, not there, the face have it changing its sort of its symmetry. You get a sort of twisted look. I'm trying to not be too technical with my answers.
Yeah, definitely.
Or there might be a problem with speech, able to express something or understand something. Those are some of the key signs that say that there's a stroke happening. And the stroke can happen where it's a blocked off vessel, or the stroke can happen because the vessel has erupted or broken, or we call it a hemorrhagic stroke. So there's a bleed in the brain. And both of those cause problems related to, depends on which side it is. So if the bleed is on the right side, you tend to have left side physical and problems. If the bleed or the stroke, ischemic strokes on the left side, they get right side problems. And sometimes if it's in the center, you get different types of problems as well, which related to speech and swallowing and so on. And so that's why one of the key things that happen in stroke is that people have swallowing, the problems with swallowing, because certain centers of the brain are then cut off because there's no blood supply. And therefore those areas which require nervous activity go back and forth are unable to operate. So that's what stroke is in a nutshell. We have seen, and I've seen it, and this is what we call anecdotal, or this is not done any research on it, I've just seen it in my experience, where sometimes people come in with a heart attack and end up having a stroke, or come in with a stroke and end up having a heart attack, because the blood vessel is the same tree that is going from the heart to the rest of the body. Or you might have problems below the waist, the vascular problems. People get problems with ischemic leg, and they have to have that sort of stuff. So it's kind of, even though it's not the same thing, they tend to be connected from time to time. And the treatment and the management is both. You're dealing with making sure that you keep control of the blood pressure, you keep control of the cholesterol levels, you keep control of people activities so that they have a little bit more strength to be able to do some of the basic tasks, etc. Those are the ways going forward.
Awesome. All right, and of course, remind us about high blood pressure as we move into the modifiable risk factors.
So when we were talking about the issues related to the heart, we were talking about the vessels of the heart and how changes in the vessels of the heart due to plaque and cholesterol and other factors, clotting factors, might lead to heart attacks. And we talk about the same thing in the brain. All of this is happening in what we call the vascular system. And the key, one of the key things about the vascular system is blood pressure. We maintain a blood pressure to keep us upright, to keep us going. And the idea is to have a normal blood pressure, which could be described, if you put a cuff on, 120 over 80 would be considered a normal blood pressure. But what has happened over the ages is that as people get older, as people have other risk factors, including obesity, including high cholesterol, etc., they tend to have blood pressures that are higher than normal. So that's why we call it high blood pressure. And what we know is that the higher the blood pressure, the more likely that there are going to be consequences. The consequence could be stroke, could be heart attack, could be heart failure. The consequences could be kidney problems or other organ damage as well. So high blood pressure is something that we have to keep checking. It's related to our intake of salt, and if we have a very salty diet, we tend to have higher blood pressure, and that means that we have to start early. We're talking about, from childhood to make sure that you keep your blood vessels healthy. Because the healthier your blood pressure, your blood vessels over time, the less likely you are to have blood pressure problems as you get older.
Okay. So persons with high blood pressure, we want to prevent having heart disease. Is it a definite must that we develop heart disease if we have a high blood pressure?
No, it's not a definite that if you have high blood pressure that you will end up having a stroke or a heart attack. But if you were to take a room full of people with hypertension, and you had another room full of people with no problems with blood pressure, the likelihood is that strokes and heart attacks are going to happen more frequently in that room of people with high blood pressure than in the room of people with low blood pressure or normal blood pressure. So the critical thing is that the risk is there, and once you're in a situation where you don't modify your risk, so you don't lower your blood pressure, then it's more likely to happen than not.
Right.
Yeah.
And I mean, medication adherence is always a tricky topic. Several persons we meet as we are conducting the LIFE project,
Yeah.
we find that the blood pressure is not controlled at all. And, some of the reasons would be that the medication doesn't allow them to live their normal life. So, you have medications that would cause them to urinate frequently, and, they don't want any mishaps happening while, they're out and about in their, daily life. So can definitely help.
So in terms of, what we're talking about is prevention and management in sort of one under one umbrella. Prevention doesn't start at tablets. Prevention starts with lifestyle changes, and those primarily include being a little bit more physically active, reducing salt in your diet, making sure that your levels of cholesterol in your bloodstreams are in the normal range, making sure that you don't get conditions like diabetes, which is once you get diabetes, then everything goes wrong. Making sure that you are using a lot of water, so that less sugary drinks, etc., and you use a lot of water or natural fluids like coconut water, for example, which are less likely to cause you any harm at all, and reduces your risk. When those things are not happening and your blood pressure is still high, if we leave the blood pressure alone, then the consequences, of course, include heart attack and stroke. And that doesn't necessarily have to be next week. It could be in 30 years, or it could be in 20 years, right? And so what your physician, your doctor will do is to say, well, let's take this combination of tablets that have been shown in clinical studies to reduce blood pressure by a certain amount. And people might find that they only need one tablet, or they may need different types of tablets to keep a control of the blood pressure. All tablets, as far as I can perceive, have some side effects related to them. And some of the design of the tablets, of course, are designed for particular side effects as well. So some people might take what we call water tablets or diuretics. The purpose of that is to get rid of salt through the kidney. And in order to get rid of salt through the kidney, then you need them to diurese or to pass water. And in passing water, then they reduce the salt and they will reduce their blood pressure. And so some of those, what you're talking and referring to about people not wanting to take their medications because it might cause a problem with them as they go out in their daily lives. It's about managing that rather than just saying, I won't do it, because eventually it will catch up on you. The long-term consequences of not treating your blood pressure will catch up on you. And similarly, other blood pressure tablets work in different ways to reduce the blood pressure, and may affect the body as a side effect. They're multiple. And what I usually suggest to individuals is that you do risk management all the time. You stand up at the other side of the street and you work out in your brain whether or not you'll take the risk to cross if you see a car coming down the road, or if you'll wait until the car passes. That's risk management. And individuals need to take account of that when they're looking at their health. So if risk management is you have a nice breakfast, but it is rich in carbohydrates and it's not healthy. You take a decision that, okay, I have a healthier, I'll have a smaller portion, I'll have a healthier combination of foods. It's the same thing related to taking tablets. You can say, well, my activities in terms of physical activity, etc., is not sufficient to keep my blood pressure in the normal range. So in order to avoid a long-term situation where I have a stroke or something like that, I'll take the risk of the side effects with these blood pressure tablets, because that is a way of reducing things. Now, obviously, as you live long enough, then things are going to happen. There's just no way of escaping that.
Yeah.
So if you're interested, I read something that if you're interested in longevity, then you must be interested in aging. So if you want to live long, then you have to get old, right?
Yeah.
There's just no way around it. And as you get old, even if you do everything perfectly, it's appointed unto man wants to die. And so, that might happen.
Yeah. Yeah. Thanks for that, Prof. Which brings us into the other strategy of blood pressure management, weight loss. Of course, you mentioned a little bit of it earlier, but just want to point out again that weight loss also plays a part or a role in blood pressure management, and of course, ultimately heart disease.
Yeah, so we have some really good experience with weight loss and reduction of risk and reduction of levels of diabetes and hypertension. We've done a couple of small studies here in Barbados where people work towards weight reduction through carefully managing the number of calories that they consume. And so when I say carefully managed, in other words, you want to have a calorific meal that has all the key things, key ingredients, minerals, vitamins, etc., that are required to keep you healthy. If you limit the calorie count in those populations, and these work have been done also in the UK as well, so in larger populations and of cohort or number of patients than ours, and as clinical trial, that those who have lost some weight are more likely to stop taking their medications because their blood pressure becomes normal. You don't need to take a tablet to keep your blood pressure normal if your blood pressure is normal, or their sugar levels become normal. They don't need to take insulin or other medications to keep their sugar in a normal level. And those who sustain the weight loss over time have a better chance of sustaining their newfound normal glucose levels or normal blood pressure levels. So weight loss is a critical thing. It doesn't have to be as stringent as being really hardcore in terms of limiting your diet, as they say in certain ways. It just have to be you can do it in a natural way where you are a little bit more responsible in what you consume and how much you consume, and the long-term consequence of that is that it's what we call the energy balance. Your body requires a certain number of calories to function. If you eat more than that, then it's going to store and becomes fat. It doesn't happen in everybody, so not everybody gains weight, right?
Right.
Just bear that in mind. And so one thing you should take away from there is think that only people who have gained weight are going to get all these problems. Heart disease, hypertension, stroke, diabetes occurs in people who would consider to have zero fat in their body as well, right?
Mhm.
Athletes and so on get diabetes as well. So
Okay.
you have to appreciate that you can't just look at the outward appearance. It's what's happening in the inside, in the blood vessels, in the systems that keep the body going forward. That is important in where your risks lie as well.
Awesome. Thank you. And then I think the other lifestyle practices that we haven't touched on quite as much yet would be smoking and alcohol consumption. How do these relate?
Smoking has been determined, and this is causal, to increase the risk of outcomes. We're talking like death from heart attack and stroke and other conditions like diabetes. It's been associated from studies, from observation in individuals, that people who stroke are more likely to have these problems, and therefore there is a need to reduce consumption of cigarettes and smoking related material to reduce the likelihood of diseases like heart disease and stroke in the future. And there are multiple studies, including the studies in the UK and the US, where smoking has been found to be an important factor. What was the other one?
Drinking alcohol.
Alcohol. So the story with alcohol is slightly more complicated, because it depends on how the study is done or where the study is done. You might find that those who consume a lot more alcohol. Remember, alcohol, some are calorific as well, right?
Right.
So those who consume a lot of alcohol are more likely to have some of the risk factors related to heart disease and stroke and diabetes, etc. Sometimes it's, when you say alcohol comes in different forms. It might be in a bottle of wine. And you'll say, oh, when I go to the people in Italy, they drink a lot of wine, or in the Mediterranean, and they don't get much problems. But you have to look at what the other things that they're doing as well. You can't just take wine as its own. They're having a better diet, they're having a more active lifestyle, and so on. So, it will appear in that population that having a glass of wine is not harmful. But there are other, alcohol which are spirit-based, like rums and gins and whiskeys and so on. They are associated with other conditions like cancers and so on as well, but also related to liver issues and then heart problems as well. So it's a very difficult one with alcohol to sort of say whatever. I think that the recommendation is not to be excessive in your activity in relation to alcohol, and to drink in moderation or not at all. And moderation, you know, is a very well used word, but moderation doesn't mean 20 for you and 15 for me. You know, moderation is really the lowest amount that you should consume. You know, of those things. I wouldn't say cigarette in moderation. I would say absolutely no cigarettes whatsoever. But there's slightly different advice given in relation to alcohol.
Awesome. Thank you so much, Prof. Oh my goodness. Indeed, this was a great session, a great discussion, and you touched on so many different pieces and topics, and of course, the different practices, lifestyle practices, and you know what we should be doing in order to not just manage heart disease and you know different non-communicable diseases, but also prevent. And of course, I always say prevention is better than cure. So at this time, we're gonna open up the floor for different questions. Of course, I saw a few messages in the chat, and I saw earlier, right? So one person said that, yes, that's correct. I got a stroke, but no heart attack. So thanks for sharing your experience. Marsha Brown asks whether or not the recording will be available. Yes, the recording will be available on our YouTube channel. So once you search for UE Care, CAIHR, you can watch all our different live talks, including this one. All right, and of course, Dr. Toler-Reed shared that it was a privilege, though, to have been able to contribute in a small way to your decision to pursue medicine and cardiology as a career, Prof. Anderson. Awesome stuff.
So I turned the speaker off just so a little bit of noise around it. But yes, thank you very much.
That's okay. That's okay. All right. Are there any other questions or any other comments? No? All right. Go ahead, Dr. Toler-Reed.
Oh, sorry, I'm walking. I hope you can hear me at this point. No, I just
We can.
Yeah. So well, just as Professor Anderson said, you know, the heart disease is a big thing, and it's a third of deaths worldwide, and there may be like 500 million people living with some sort of heart or circulatory disease. So, you know, as somebody mentioned that had a stroke, not a heart attack. We call a stroke sometimes a brain attack, but the underlying risk factors, the conditions that predispose are the same. And I wanted to add to, Professor Anderson is familiar with the InterHeart study and the new risk factors, stress and depression, anxiety, hostility are all important. And I guess we'll be examining a lot of these in the LIFE project. So it's really important that people participate and engage and stay engaged. So well done. I'm really happy about this. This is really a tremendous undertaking, and I think it's going to yield some really valuable results. It's going to help us craft the best possible public health and healthcare policies across the Caribbean.
Indeed.
Thank you. I enjoyed the talk, Simon. It's great to see how you've developed. Thank you.
Thank you too, Dr. Toler-Reed. Thank you too. Awesome. All right. We have Rayan Dwyer as well. The question.
Good evening, Prof. Just just out of curiosity, coming up in science, you learn that high levels of LDLs and triglycerides predispose to various heart conditions on others. But what if you have someone has consistently low LDL, low triglycerides? Are they prone to any known disease? Is that something detrimental to health based on your experience?
Thanks for that question. So yes, when we talk about cholesterol, we sort of group everything into one package, the total cholesterol. But of course, cholesterol is made up of a variety of components, including high density lipoproteins and LDLs or low density lipoproteins. There are also other things like the apoproteins and the ApoAs and the ApoBs that are all part of the cholesterol story. Some individuals have inherited predisposition to have high levels of cholesterol and the LDL, etc. And those manifest in plaques and blood vessels. And sometimes you can see manifestations on the skin as well, where the levels are extremely high. And typically you have to take very strong measures to deal with that. In terms of triglycerides, from my memory of biochemistry and from my memory of biochemistry is related to what you're eating at the time. So you can't necessarily map triglycerides levels over time as you would do cholesterol. So if you're having a low-fat, long-term low-fat diet, and if you measure triglycerides in those situations, you tend to get lower levels. That doesn't have any problems at all when the levels are low. Similarly, some people have higher levels of HDL and low levels of LDL. That does not mean that that individual will not have consequences related to cholesterol. Going back sort of 25 years, we did studies in Caribbean populations in the UK. In other words, migrants to the UK who've lived in the UK for many years. And what we used to notice is that we'd measure their cholesterol profile, the lipid profile, as we'd say. They would have low levels of triglyceride compared to other populations. They'd have high levels of HDL. They'd have low levels of LDL. And what we were noticing was that those individuals were less likely to have heart attacks, but they would still have very high prevalence of stroke in those communities. So zeroing in on one component is useful when you're trying to sort of work specifically related to that. But what we found is that you have to look at the big picture and everybody, and that it's a big picture that's going to cause a problem, not the minutiae one situation, right? Because the body system works in that way. It's not just focus on one pathway which could cause you to have low cholesterol levels. And sometimes what you find is that it's in individuals' dietary practices, etc. So those who are more vegan, who have less sort of animal-related foods, tend, based on some of the studies, like for example, the studies in Adventist populations in the US, Loma Linda is an example, which has been studied by institutions like the University of Harvard, have shown that those populations tend to have a longer lifespan because they're not exposed to cholesterol from other things. But as I said at the beginning, the level of cholesterol is not just related to what you eat. It may be inherited, and if that's inherited, then you might find that even though you might eat absolutely no fat, like Jack Sprat, you might still have a problem with a condition or an outcome. Thanks.
Thank you too, Prof. And I see a comment in the chat as well from Dr. Tullery in response to your earlier message, including sleep as a risk factor. And he says that it's perhaps the most underrated risk factor for heart and circulatory disease. So yeah, thanks for that. All right, any other questions, burning questions as we close off? No. All right, again, thank you so much, Prof. Anderson, for spending some time with us for the live talks for this month, looking at heart disease and its risk factors again. Thank you for all the questions and the comments, Dr. Taylor-Reid as well for, being on tonight. And just to share that next month, which is Heart Disease Month, actually Awareness Month, we're going to be talking about heart disease, but checking for heart disease this time. So what do we do to find out if we have any of the conditions? And of course, Prof. Anderson actually, talked about a little of them. So we're going to be able to elaborate much more next month. So remember to tune in the 4th Thursday of February, which is February 23rd. We're going to send out a post again, of course, as well as the calendar invite. So looking forward to seeing you next month. And again, spread the word, tell persons about the LIFE project, and of course, encourage them to sign up. Have a good night.
Looks like nobody wants to leave your talk.
Great session, Prof.
All right,
Great
see you later.
session.
All right. I'm sorry about a little bit of noise at the end. My colleagues are now. Today is the last day.